Hi, I'm Dr. Sudhakar. I'm the Director of Trauma at Royal Perth Hospital. I'm going to talk about tension pneumothoraces. 85% of people who have trauma, particularly blunt trauma, will have some form of chest trauma. The majority of these are treated quite simply with good analgesia, oxygen therapy, physiotherapy, and mobilization. So in the pre-hospital area, most of these should not cause too much trouble. However, a small percentage of these people will have a life-threatening condition called tension pneumothorax or even a tension hemothorax. It is important that you understand how to diagnose these conditions, and it will require a knowledge of the physiological changes that occur with a tension pneumothorax, and it will require a knowledge of the physical signs you might find in these people. Now, to be quite honest, it's quite hard to auscultate chests even in a hospital emergency department, so I'd imagine it's really difficult out in the field. So the cardinal signs, such as deviation of the trachea, a patient is dyspneic, patient's really struggling to breathe, reduced cardiac output, and sometimes even an asymmetry of the chest may make you think about a tension pneumothorax. Treating a tension pneumothorax is a matter of urgency. You only have a short period of time before the person will completely lose their cardiac output and die from lack of cardiac output or in fact lack of ventilation. The traditional method of treating a tension pneumothorax has been the use of a needle thoracostomy, and traditionally a 14-gauge cannula such as this, there are longer ones than this, has been used as an immediate decompression in the second intercostal space. It is also important that you learn the absolutely correct landmarks for where this needle should go in. Over time, however, with the advent of good research and good imaging, we have found that anything up to about 33% of these needle thoracostomies, this particular product, will not actually reach the actual pneumothorax. The reasons for this are either the position's incorrect, patient's chest wall thickness is quite thick and beyond the length of this cannula. So this cannula is about 45 millimeters. There are a couple of really good studies using CAT scans that have looked at the thickness of the chest wall and have shown that the average thickness of chest wall, this is males and females, is around 43 millimeters. So in at least about 33% of people, and even up to 50% in some studies, one of these will not actually reach your tension pneumothorax. So you might say, well, what about laterally, in the lateral chest wall? Again, the same problem exists. The chest wall is just as thick laterally as it is anteriorly. So both CT studies and ultrasound studies have confirmed this. Having recognized that, and also recognizing that our population is also getting more obese, we know that this is a problem. So can you use longer catheters? Well, you might say, well, longer catheters will solve this problem. Yes, they will, but the chances of injury to the pulmonary vessels or even to the heart start to rise. So the risks of using longer catheters will probably outweigh the advantages of it. So what can we do instead? We know that it's a life-threatening condition. You have to transport the patient to a hospital where definitive care using a chest tube can be instituted. We know that at least 85% and probably more of people who get a needle thoracostomy will actually need to move on to a proper decompression using a chest tube. So you pretty much can't get away without a chest tube at some point. Putting in a chest tube in the pre-hospital area is going to have lots of problems, not the least of which is being in a dirty environment and not having asepsis. So the alternative to this lack of decompression with a needle thoracostomy and the alternative with a chest tube is somewhere in between. And that in between position is what we are referring to as a finger thoracostomy or a simple thoracostomy. So both terms will be used, either finger thoracostomy or a simple thoracostomy. A simple thoracostomy involves putting an incision in the lateral chest wall in that area where we would normally put a chest tube in, making a wide enough incision, putting your finger in and confirming that you're actually inside the pleural space, sweeping your finger around, making sure that you're definitely inside a pneumothorax, and then releasing your finger and allowing that tension to decompress. Now, because the tension pneumothorax will reaccumulate, you can actually repeat that procedure again through that very same hole. Put your finger in using a sterile glove and putting your finger back in and repeating that procedure and allowing the tension to decompress. So that allows you to actually safely decompress. You're not second guessing yourself, because we know that only 15% of people will actually show good response to that clinically. That is, in the 85% of people, other 85%, there's another problem happening with the patient. So you need to be absolutely clear in your mind that you've decompressed, and the best way to do that is with a finger. If you do it with one of these, you could be second guessing yourself to say, have I or have I not decompressed that? So in summary, tension pneumothorax is a life-threatening problem. It's important that we diagnose it quickly and that we treat it effectively using a finger thoracostomy rather than a needle thoracostomy, because the needle thoracostomy is going to fail in about 33% of people. I'm Sudhakar Rao. This is 5 on Friday. Thank you for watching.